webinar on improving quality of pediatric care, which is co-hosted by the Pediatric Quality of Care subgroup of the Child Health Task Force and the Network for Improving Quality of Care for Maternal, Newborn and Child Health. My name is Donabedian. I'm one of the co-chairs of the Quality of Care subgroup, and I will be moderating this session together with one of my other co-chairs, Patricia Jodry. Bonjour à tous. Ce webinaire sur l'amélioration de la qualité des soins pédiatriques co-organisé par le sous-groupe pour la qualité du soin du Task Force sur la santé de l'enfant et le réseau pour l'amélioration de la qualité des soins pour la santé maternelle, néonatale et infantile. Je m'appelle Anne Détienne, je suis l'un des présidents du sous-groupe qualité du soin et je vais modérer cette session avec l'une de mes coprésidentes, Patricia Jodry. The main language of this webinar is English. We are, however, trying very hard to find feasible ways to enable our French-speaking colleagues to participate. All slides are bilingual, English on the left side, French on the right side, and we will translate questions and answers in the chat. You can pose questions in French as well. We invite your feedback on this experience. La langue principale de ce webinaire est l'anglais. Nous nous efforçons cependant de trouver des moyens réalisables de permettre à nos collègues francophones de participer activement. Toutes les diapositives sont bilingues, anglais à la gauche, français à la droite, et nous traduirons les questions et les réponses dans le chat. Vous pouvez également poser des questions en français. Next slide, Emma. First, we want to remind everyone about the goal of the Child Health Task Force, which aims to strengthen equitable and comprehensive child health programs for all children 0 to 19 years through primary health care. Within the Child Health Task Force, the Pediatric Quality of Care subgroup aims to create a platform in the child health community to advocate for, learn, and provide targeted support to countries to improve quality of care for children. Premièrement, nous voulons nous rappeler à tout le monde l'objectif du groupe de travail sur la santé de l'enfant qui vise à renforcer les programmes de santé infantile équitables et complets pour tous les enfants de 0 à 19 ans par les soins de santé primaire. Le sous-groupe qualité de soins vise à créer une plateforme dans la communauté de la santé infantile pour plaider, apprendre et fournir un soutien cible au pays pour améliorer la qualité et de vie de soins des enfants. Today, we want to educate ourselves about key principles and approaches for improving pediatric quality of care and learn from countries. Next slide, Emma. We will have 2 sessions with 2 speakers, each followed by a discussion. First, Kathleen Hill, Senior Quality Advisor for Momentum Global Leadership at JPIGO, and Dr. Soji Teti, Vice President of the Institute for Healthcare Improvement in Ghana, will introduce principles and approaches for scaling quality improvement, followed by a discussion. In the second part, Ambrose Aguayo, Head of Epidemiology and Demography at the Kemry Wellcome Trust Research Program in Kenya, and Mike English, Professor for International Child Health and co-lead of the Health Services Unit at the Kemry Wellcome Trust, will share lessons from the Clinical Information Network in Kenya. Aujourd'hui, nous voulons nous renseigner sur les principes et approches clés pour améliorer la qualité des soins pédiatriques et apprendre des pays. Nous aurons 2 sessions avec 2 orateurs, chacune suivie d'une discussion. With this, I will hand it over to Kathleen for the first presentation and to Patty to moderate the first session. Over to you, Kathleen.
Thank you very much, and good morning, good afternoon to colleagues. Bonsoir, bonjour à tous les collègues dans les pays francophones. C'est vraiment un plaisir d'être avec vous. It's a pleasure to be with all of you today. As mentioned, I'll be speaking in English, but we do have the slides in the text in French on the right, and we'll be happy to take questions in French and English at the end. So thank you very much for the opportunity to present today. I'll be sharing some reflections on key principles, approaches, and opportunities and challenges relating to quality, improving quality of pediatric care at large scale. And we hope that some of these reflections will provide a useful framework, because you'll hear in the country presentations that many of the themes will be taken up with very concrete examples. So why does quality matter? We know that there are serious deficits that persist in quality of pediatric care, maternal newborn care as well. And that in low resource settings, poor quality of care is actually now a bigger barrier to reducing mortality than lack of access to care. The Lancet Global Health Commission on High Quality Health Systems did a very nice analysis that I encourage you to look at. And we know that access is, of course, very, very important, but that quality is really now the next frontier. That high quality systems could prevent, millions of preventable child and newborn and deaths really of all people. And that we know that there are huge costs to poor quality care. It's estimated that the cost of poor quality care in low resource settings is approximately 6 trillion. And this relates both to costs of the health system, as well as lost productivity in terms of economic costs for a country, as well as, of course, the devastating financial and emotional costs for families that bear the brunt of poor quality of care. And that universal health care will be an empty vessel unless we ensure that quality is at the center of universal health care. Next slide, please. So as many of you know, there were 3 global quality reports published in 2018, and I'm sure many of you are very familiar with these and encourage you to look at them. And while the different reports, have different pieces that are very interesting, all 3 reports really emphasize the importance of health systems and governance for quality. And we'll be focusing quite a lot on this piece throughout these framing remarks, and I think you'll hear it come up again and again during the presentations that follow. Next slide, please. One useful framework for thinking about quality health systems is Juran's Trilogy. And I do apologize, I know it's a bit busy with the French and the English, but if you'll bear with us, we'll try to make this a little bit simple. As many of you know, Juran's Trilogy involves 3 legs to the stool, if you will, or angles of the triangle. And one has to do with quality planning. And this really has to do with planning a system to be able to support, the delivery of quality health systems at scale. And the examples of this would be, for example, having a costed national quality strategy, having quality management structures throughout the health system within the Ministry of Health, whether it's a freestanding quality division or whether it's part of respective technical divisions within a ministry, having quality management structures like quality focal points or lead quality managers within a district or a region, regulating the health workforce, accrediting healthcare facilities, etc. Another very important part of Juran's Trilogy is quality improvement. And we'll be talking a lot about quality improvement today, but we did think it was useful to frame it within this larger framework because, of course, all of these pieces are essential for delivering quality of care within a system. So quality improvement is really about changing the performance of a local health system to a higher level. It's an intentional process of driving change to move from one level of performance to a higher level. And we'll talk more about some of the key principles behind quality improvement. And then quality assurance is, in one sense, and perhaps this is a bit of a simplification, but it's really about assuring that performance of a local system once it's been improved. So examples would be external verification, external assessments of quality. They might be used to help design improvement, but they're also a check to see, are you actually sustaining improvement once you've improved the performance of a local system to a higher level? And you'll hear again and again that learning systems are at the heart of this, and we'll talk more about that just in a minute and also throughout the country presentations. Next slide, please. Donabedian provided another useful framework about conceptualizing and measuring quality. And although I think it's still useful to mention this framework because it's quite elegant and simple, and many of us use it. And for Donabedian, it was useful to conceptualize the measurement of quality around inputs, which are really the sort of the service delivery readiness components of a health system, if you will, simplifying a bit. Are there skilled health workers in place? Are there commodities? Are policies in place, et cetera? And it's the interaction between those inputs, that's that health system, that readiness of the health system, with the actual processes of healthcare and of management with respect to health system functions, as well as management of healthcare services at the service delivery level. It's really the interaction between these two which is essential for producing the health outcomes. And I think many of us might agree that, historically in global health and in many health systems, we focused a lot on the inputs, but really not enough on the actual processes of care, and that this really is an enormous contribution of quality. It's looking at this whole piece and looking very closely at the processes themselves with respect to healthcare services as well as managerial processes across a health system. Next slide, please. Next slide, please. So we can take the Donabedian framework and we could apply it to analyze common quality gaps and drivers with respect to pediatric quality of care. And this is not meant to be exhaustive, but it's just to sort of give you a flavor of how we can think about this. And so for inputs, for example, we often look at things like commodities, skilled providers, but we could also look at, are standards clear? Are they clear at the national level? Are they available at the subnational level? Are they really, evidence-based and up-to-date, including global standards? Processes of care does care adhere to evidence-based standards? Are services organized? Are the processes of care by which patients move throughout a system to receive care, is that appropriately designed and implemented? So for example, that the very sick child who comes in with danger signs is immediately recognized, that there's a triage system that immediately takes responsibility for the care of that child. Is care uncaring, another very important part of processes, and that it is really these pieces, these gaps, these drivers that drive the results with respect to quality of care, health outcomes, experience of care, and ultimately low utilization of care when these are not positive. Next slide, please. So what is quality healthcare for children? Well, in 2001, as many of you know, the Institute for Medicine published really a seminal report, this is 2 decades ago, that launched in essence in the US a lot of the focus on quality. And it postulated a number of domains related to quality, many of which have been adapted and that you'll see in the domains of quality in the global reports and many of the global guidelines. And that has to do with, is care effective? Is it adherent with evidence-based standards? Is it safe? Does it not harm children? Is there iatrogenic harm that's actually being created at the point of healthcare delivery? And safety has been a huge focus of quality improvement efforts, particularly in higher resource settings, and I think increasingly in lower resource. Timely, is it provided when it's needed? Is it efficient? Does it not waste resources? Is it centered on the child, on the rights of the child? And does it emotionally support and respect children and their families? Is it equitable? Does it not vary based on personal attributes? For example, a child living in poverty. And then coordination of care was not part of the original Institute of Medicine domains, but I think many of us use this often as a key goal of quality as well. Our services coordinated across time and levels of care. This is so important for children, of course, both with respect to their growth and development, health prevention, as well as the acute care of a child, for example, with acute asthma. Is the care coordinated from home to primary care to hospital level, et cetera? Next slide, please. So there's been I think you'll hear throughout the webinar, there's a lot of focus on the importance of leadership and leadership to drive quality improvement at large scale, that it really takes a system, leadership at national level, at regional district level, at service delivery level, and leadership that is working closely and aligning with critical stakeholders, community, civil society, professional associations, UN agencies, partners, academic institutions. And you'll hear this during the next 2 presentations. You'll hear a lot about the stakeholders and the importance of these stakeholders. And I know many of you are stakeholders that are on the line, as well as, representatives of government. So we are all really a community together. And in the 3rd presentation and 4th, you'll hear about a partnership between an academic institution and implementers of quality in Kenyan hospitals, improving quality of pediatric care. Next slide, please. Next slide, please. So some illustrative approaches to improving quality at scale. Often increasingly in many settings there's an emphasis on working across large networks of sites to drive care. That, you know, I think historically, maybe a decade, 2 decades ago, there was a lot of focus on the individual quality improvement team and what that team was doing. That is incredibly important. It's at the heart of quality. But increasingly now, our focus is really on what does it take to drive improvement at quite large scale. And that really has to do in many settings with working across networks of sites that share a common vision, measurable aims, that are tracking common measures, in which there's an intentional effort to build capabilities related to managerial, clinical, QI measurement to strengthen health information systems, to be able to actually measure the quality, to support learning systems across sites, to build the motivation and trust of healthcare professionals, to tackle the kinds of norms, often implicit norms that may not be obvious to outsiders, to really shift a culture towards quality, to leverage existing system structures and processes and engage stakeholders. And you'll hear more about that in the slides in the presentations that follow. Next, please. I think actually we might have skipped one slide, but I'm just going to say it out loud because one of the themes that I would like to share, that I think many of us agree with, is that there's not a single QI method, that there are some key principles, and that if we think about key principles, if you don't mind just backing up 2 slides, I think you'll see it. This was actually a slide I did want to emphasize. Yes, here, thank you. That there's no single method per se, and I think although many partners and many institutions may promote a particular method, I think for many of us it's more useful to think about some key principles with respect to quality. And some of these principles might be, for example, having ambitious, measurable goals and aims that are focused on priority areas related to high burden of child mortality, related to quality gaps, related to, you know, local political health system priorities, having regular measurement of selected quality indicators, so not occasional, extensive quality of care assessments, but real-time regular measurement and monitoring of indicators to basically help guide your improvement and tell the managers and the improvers whether or not care is improving. Another critical principle is a change management strategy. And I think I can't say enough about this. What I hear a lot about is the measurable goals, aims, a lot of the measures and the measurement, but without a change, a very intentional focus on change and a change strategy, we will not achieve a higher level of performance of a health system. We will not close those quality gaps. And then the importance of multi-cutter teamwork. We don't have time in today's presentation to go into the many kinds of QI tools that can be used, but I have listed them here and we're glad to, recircle back on them. But they are here if you'd like to look, and I know many of you are very familiar with them already. If you could skip now 2 slides ahead, please. So, if you could click once again, please. Thank you very much. I think it's Emma who's doing this. Thank you, Emma. So back, please. So if we think about supporting a QI team, and of course, if we're working within a network and trying to improve quality of care at scale, the importance of supporting teams is critical. So supporting QI teams to be able to identify performance gaps, analyze the root causes of those gaps with respect to inputs, with respect to processes, with respect to motivation, implicit norms within a culture, et cetera, and to manage change and continuously measure trends in quality of care indicators. And this is a picture of a quality improvement team in a hospital that includes, multiple cutters involved with the care of a child, a nurse, a doctor, a health information officer, a laboratory technician. And I think what many of us really appreciate about quality is that it's these local stakeholders, these local actors who understand the system and have the expertise to be able to generate the great ideas, to test them. And it's really tapping that local knowledge, that it's not someone sitting in London or Geneva or DC, but it's really, or, a capital of a country necessarily. It's really those local actors at the local level that really understand their systems and can generate the great ideas to make changes. Next slide, please. I'm going to fly through these last slides because of time, but I just wanted to share some very brief challenges, but there are also opportunities related to measurement. And I think many of us will agree that many hospitals and clinics have little or no information on processes and outcomes of care, and that this is a fundamental problem for improving care at scale. And this is from a paper from Iramu et al. That was co-authored by Mike English and Ambrose Aguayu, who you'll be hearing from. But I think all of us recognize and understand the challenge and the opportunity of strengthening health information systems to be able to measure and monitor, indicators of processes and outcomes of care, and also the recognition that different actors may have different information needs. A manager of a large-scale improvement effort in a region versus, a frontline member of a QI team. Next slide, please. Another challenge is that historically, many healthcare workers and managers have not received training in quality improvement and health systems and measurement. This is starting to change, but this is also a challenge. And you'll hear a little bit about this also in the slides that follow, but this is something we need to think about and really focus on. And next, please. Slide. I'm now just going to end by mentioning that, as many of you know, the WHO Quality of Care Framework Network was launched in 2017, and I think you'll recognize from a lot of the strategic objectives, leadership, action, learning, accountability, that these really very much resonate with the themes that we've been emphasizing and that you'll hear in the upcoming webinar. We do have the link to this network for those of you who are interested. And next slide, please. The WHO Pediatric Quality of Care Framework and Standards that were published in 2018, 1 year after the launch of the network, provide an enormous opportunity for us all now to really drive an increased focus on improving quality of pediatric care. And I encourage you to read them. There's an effort now that many of you are aware of that WHO is leading, working with UNICEF and many others to prioritize quality of care indicators with respect to improving pediatric care. And I encourage you, we all encourage you to look at these. I think it's a very useful framework, and we look forward to really taking this forward. I'd like to thank you for listening. I'd like to now introduce my colleague, Soji Teti, who will be presenting on a large-scale quality improvement effort in Ghana, and I think you'll hear many of the same themes come up again. And at the end of my PowerPoint that will be shared later, there are many references related to the Quality of Care Network for those of you who are interested in exploring more. Soji, I hand it to you. Thank you.
Thank you very much, Kathleen. And I think you've done an excellent job of laying the scene for what this means for a national level implementation, how all of these principles and processes come back together. Could we move to the next slide, please? So I'm really going to focus on a Ghana country case study where an initiative happened at large scale to reduce preventable deaths among children less than 5 years old. Next slide, please. And this, I think you're still on Kathleen's slides. Thank you, thank you. Next slide, please. So this really is what is a project that is known as Project Fire is Alive, which happened for over a 7-year period. And it was a large-scale quality improvement initiative that really aimed at reducing preventable deaths among children less than 5. And it was done as a partnership between the Institute for Healthcare Improvement, Catholic Health Service, which is a faith-based organization in Ghana, and Ghana Health Service, the main public sector provider in Ghana, funded by the Gates Foundation. And here really is how we begin to frame the conversation, in that it was aligned to, at the time, Millennium Development Goal 4, that of reducing child deaths by 67%. And we used the quality improvement approaches, basically as described, where we set ambitious aims. We adopted a view of the system in looking at where the process flaws were, and then also promoted rapid cycle tests to tackle the direct causes, being malaria, diarrhea, respiratory conditions, and then the indirect causes, which I'll address shortly. Next slide, please. So in terms of the scale up, this was not some initiative happening in a couple of districts that we did, but it was really a national scale up effort. And you would see how in wave 1, we focus on 3 districts. In wave 2, scaling up to over 38 districts in the whole of the northern half of the country. The third wave giving us an opportunity to focus on 9 district hospitals, learning what it would take to reduce preventable deaths among children less than 5. And then in what I'm terming with 1R here, focusing on referral practices. So how to address the continuum, that integration element which Kathleen talked about. And then wave 4, the final stage where we did a national scale up. And also worth calling out the over 700 quality improvement teams that were formed by the time the project ended over the entire period. I think cumulatively, we can talk about the project being effective in 80% of the public sector hospitals and about 30% of the districts. Next slide, please. Here, we begin to talk about the way we conceptualize scale up, using a framework that we often refer to at IHI. So, and that is really going to guide how I go through the subsequent slides, the setup phase, and then how to build up your scalable unit. The scalable unit here refers to your smallest administrative unit, that would then lead implementation. Because if you're thinking about implementing at scale, then your idea is how do you operationalize it at the administrative unit so that the structure can take up the implementation. And for us, that was the district health system. And then you test up within the scale. If you have a model that has worked, you test it in a variety of settings to be sure that it can take roots before you go into full scale. Next slide, please. So basically, that is what we did, and I would walk subsequently through. Next slides, please. Yeah. So once you're done, then the question becomes how you build up the infrastructure that would support whatever changes you are trying to introduce in the system. In essence, starting really with the end in mind, working very thoughtfully with managers in the health system to take this up. So in terms of will building, if you go back to the frame that I spoke about, the entry point was really through the National Catholic Health Service. And it was great because within the NCHS, there was already an articulation of their intent to transform the system using a quality improvement set of lenses. So coming in with this was not seen as new. And then also, if you talk about the fact that within the Ghana Health, if you talk about the fact that within the Ghana Health Service, there was already a national goal to reduce both child health and maternal mortality. So the whole talk about using quality improvement to improve health outcomes through promotion of the use of local data was welcome. And also, quality was not really new within the health system. There was all the structures that were in existence to drive quality assurance systems. And QI was then positioned as a supplement, and that helped us to address that Juran trilogy that Kathleen spoke about. So in terms of the quality planning pieces, the assurance pieces, and the QI being the addition that came on top. So next slide, please. Now, a little bit about the approach. So we used the model for improvement. And I mean, this is really aligned to what you have heard before. We work with teams to be able to set ambitious goals in terms of which specific processes they would improve. So you wanted to reduce how much by when, in terms of mortality, in terms of care processes, what specific changes. So teams being encouraged to look within their systems and come up with ideas that would work. And then also doing this with measurement framework. So key processes and outcome measures that would help us to track the effect of the changes being tested. And in many instances, some of these process indicators were not within the district health information systems, but we had to evolve data systems at the facility level to be able to track. And they're not leaving them at the level of ideas, but coming up with a plan, do, study, act cycle to test it. This is what we mean by rapid cycle test. Testing it on a small scale, learning, adapting, so you built enough confidence to implement. And the collaborative model became the vehicle. So over an 18-month period, 12 to 24 months, we would bring various learning units together. So depending on what your scalable unit is, it may be a number of district health hospitals or a number of health centers, but they would come together for face-to-face meetings, learn from each other, identify the root causes, be taught a number of the quality planning tools, and then go away with various ideas that they're going to test in their real healthcare settings. And we would provide intensive support. And I'm talking about the improvement advisors on the project, but then also a whole set of cadres employed within the health system who had been trained as improvement coaches from the district level, visiting the health facilities, going through the data, reviewing the trends, analyzing the data, getting management support and buy-in to be able to assess the impact of the various changes that have been tested. And using this mechanism, giving us the confidence that the things were being done to be able to address the gaps. Could we move to the next slide, please? Here, ultimately, of course, once you do all of these tests, then you get to see the various changes, which we then put together into a change package. So this is just a high-level driver diagram, or it's your theory of what you think is accelerating mortality in the facilities. Next slide, please. So this is really something that was developed for the health centers. So we looked at how to seek early care, providing prompt care, and then developing a culture for continuous quality improvement and promoting data use. So once you came up with these three primary areas of focus, you then looked at things at the community level, because as far as care seeking is concerned, the community level is the most dominant. Then the care provision facility level focus, and then the issues to do with the culture, that is where we talk about the data use and all of those other things. So we're aligned to each of these key primary and secondary drivers. We then work with the teams to come up with the specific changes that, in their view, address the root causes of the drivers of mortality or adverse healthcare processes. And then they would then test the rapid cycles around those. Next slide, please. So this then gives you an example. Here is a community health nurse, a community health volunteer, and a traditional birth attendant. The issue at stake really is to map out what happens to a woman who goes into labor from when she leaves her household to when she goes to the facility. And that was really a breakthrough experience, getting the community to work together with the health workers in this way. And there you begin to see where we may need to consult with a soothsayer, a traditionalist who would determine whether this is a complicated delivery that needs to happen in a health facility, or this is something that doesn't need to go. And how within the collaborative, we would then need to go to the soothsayer and engage, and the healthcare workers would then drive that. So you see the process map that they came up with and identifying various bottlenecks. Next slide, please. So this really looks at various innovative ideas, whether it is using pictorial mechanisms to identify anemia in pregnancy, whether it's coming up with innovative transportation solutions to take critically ill children to the facility, or engaging in outpatient education of mothers with sick children, or developing referral guidelines and protocols so that we would be able to do timely referrals. These were all innovative change ideas that I summarized on this slide. Next slide, please. Here, we focus on the hospital bit, because that initial part really had a good focus on the health centers. This is at the community level. So I'm just elevating it a bit to the level of the hospitals, because there, although we had the same drivers, and yes, you can give us all the primary and secondary drivers at once by moving ahead with the slides. Although we have similar drivers, you would see that it really followed along the lines of the 3 delays model, where we talked about delay in care seeking, delay in the provision of care, and reliable use of evidence-based protocols, because then we realized that in the hospitals, we needed to pay more attention to the protocols. So whether it's, do we have adequate staff knowledge and skills in management of the high causes of morbidity and mortality, whether it is malaria, pneumonia, diarrheal illnesses. So making sure that we focus very critically on these protocols and having them being available. And then not only just in making sure that there was head knowledge, but addressing the matter of skills, availability of drugs and supplies, all of those were very critical in addressing the high causes of mortality. And the other thing that I would call out in this theoretical framework that we put together would be the measurement system. So when it came to delay in care seeking, the question is, how do you measure delay? So something like you would measure the average number of days between falling ill and then actually arriving at the facility. And some of them aiming to reduce it for 4 days to about a day, that within a day of falling ill within my community, we would want the children to be brought to the hospital. And that leading to a lot of innovation. So mobilizing community radios, making sure that we tailor our education at the facility level to address some of these delay issues really help. And then in terms of delay in providing care, tagging folders. So making sure that there are triaging and fast track mechanisms in place so that we can quickly identify critically ill children and commencing treatment. In some instances, we came across children who would be identified critically ill, and yet mothers would have to seek permission from home before bringing them onto admission. And some of the measures that had to be put in place to make sure that whilst going through elaborate admission processes, children will be commenced as far as treatment is concerned, so that before they get a bed, they will already start treatment, so that we cut down on some of these delays. So these were the things that had to be done to be able to bring some good results. Next slide, please. This is a good example. And here you see the run chart. And here we're just looking at time series. So looking at tracking data over time. And prior to the commencement of these interventions, you see the unreliability in the health system. But then as we constantly use bedside teaching with the district hospitals, with the pediatricians, using their ward rounds to educate in protocols, you see greater reliability in the adherence to protocols. And in this particular hospital, they moved to over a 95% adherence to malaria protocols. And malaria was the leading cause of death in this particular hospital. And ultimately, they succeeded in reducing child mortality due to malaria by 70%, as much as 70%, which was phenomenal. Next slide, please. Here, I just focus on the next phase, which is moving to the test of skill. Next slide. Having tested and having developed a number of interventions, we put them together really at the level of the hospitals to show what are the various interventions that can be done. And we use evidence-based signals within the use of run charts, the data elements to show clearly that these have been tested within the teams and have been found to be effective, and put all of them together to form a package of interventions to be promoted at the hospital level. Next slide, please. Similarly, this package was then scaled up across various levels. So initially I spoke about wave 3 focusing on 9 hospitals, going to 32, 68, and by the time we completed with the national scale up, we had been able to deploy the hospital change package in over 200 hospitals at multiple levels, primary and secondary. Next slide, please. This is just to show the level of adoption, where the changes that were developed in the initial facilities adopted. And here you see across the 3 areas in early care seeking, prompt provision of care, and adherence to treatment protocols, adoption levels of between 70 to 85%. So really good adoption of the various change ideas. Next set, please. So next one, please, just to focus on a few of the results. Here we are looking at skill delivery, and in some areas in the early community level work, moving skill delivery from sometimes around 55% to almost 100% in some of those communities in which we're working, and various interventions, sometimes even changing birthing positions, sometimes providing warm drinks for women in certain communities, provided to be the game changers. And some of these are changes you will not really see in any textbook, but coming from frontline innovation. Next slide, please. This really then focuses on the hospitals. And again, in those initial set of 9 hospitals, reducing mortality by 18% over that period of 12 to 24 months collaborative. And the significant reduction in mortality was observed in 6 out of the 9 hospitals. So often people would be interested in knowing what happened in the remaining 3. And the reasons are what I've spoken about there: weak management support. So where the team did not have management support in giving them dedicated time, making sure that supplies were being addressed, you did not see that much of a reduction. And then poor team dynamics. Sometimes you would visit the facility and be told that the data officer is on leave, and so there was no access to the data. And then high attrition of core team members. You know, people have gone out, they've gone to school, and so we do not have enough people on the team who have a good understanding of the methodology to be able to work. And then challenges in the reporting of the indicators, especially the process indicators. So a facility may have the aim of commencing treatment within 5 minutes, but that means that we also have to collect data on how quickly we start treatment in critically ill children. And putting in place a system to be able to track that. And often that proved a little challenging. Next slide, please. So this is really at the end of the day when we had done the scale up into 140 hospitals, and phenomenal results, really 35% reduction in under 5 mortality globally. And then the 54% in postneonatal infant mortality and malaria case fatality. But this was collected within the project, within the 7-year duration of the project. And often people would again ask, well, this is your own data. What did the national data say? So I would go to the next slide and say that fortunately for the project happened in between 2 demographic health surveys. You know, the one that happened in 2008 and 2015. And interestingly, under 5 mortality also reduced significantly from 80 to 60 per 1,000 live births. And I would like to believe that the project and the collaboration with the Ghana Health Service and the Catholic Health Service significantly contributed. I know there were many other interventions. This also contributed. So I will just focus subsequent comments on the infrastructure for scale-up, because once you work in generating the evidence of what works, one needs not just to disseminate, but then to build the capability of the health system to take this going forward. Next slide, please. And that has led to the next work that really is at the policy level. So in 2016, working with support from the Gates Foundation, working with the Ministry of Health, the ministry has now rolled out a national quality policy and strategy, which is now currently being implemented. So promoting higher level system ownership of these interventions beyond even a project setting. And that is really great. The next slide will then also address the matter of the cost effectiveness. And indeed, in the independent evaluation that came up, talked about the fact that relative to the impact that was observed, the investment was worth it. It was cost effective. Next slide, please. This really then talks about the fact that you have an option of focusing. Sometimes people want to develop their own separate data systems. But if you really want to build national data systems, irrespective of how flawed those data systems are, we do have a responsibility to work to improve the completeness, timeliness, and accuracy of those data systems. And here you see a number of partners coming together: Malaria Care under USAID, PAC, Project 5's Alive, Ghana Health Service, then providing us the guidance where we standardize the data quality improvement protocol and worked with the data information officers to improve those various elements of accuracy as far as the DIMS was concerned, and building reliability. So if I have more time, we could go into how data gaps were closed over time. Next slide, please. Here, capability building is critical, and we focus a lot of energy in training quality advisors at the regional and district levels. And the good thing is that these were officers that were embedded within the various regional and district health directories. And so now it's joined up very neatly with a quality strategy at the national level, where the Ghana Health Service has developed quality strategy implementation guidelines, making provision for quality managers to be appointed at various levels of the health system. Next slide, please. The question then becomes how these officers get to be trained. And at the end of the project, the combined effort of the Institute for Healthcare Improvement, with providing support for improvement advisors within the project has led to the formation of a local quality institute called Ibora Institute, which is now in existence, which is now continuing to provide capacity building, nourishing the health system, and working in close partnership with the Ministry of Health and also with the Ghana Health Service. And this really has been a good legacy to leave to strengthen the ongoing mechanisms. Next slide, please. This is just another material resource that was developed, and I think it's been shared, showing various elements to pay attention to in rolling out such a similar large-scale initiative. Next slide, please. So just to call out a few lessons, that it is not a one-size-fits-all, really. There are various dimensions to the quality matter. And as Juran said, paying attention to the planning, the assurance, and the improvement elements, to needing to come up with a system that continues to train. And here, the focus should be on pre-service education and in-service as well. 3 being the importance of co-design and co-implementation, that we do not implement till we get to the end and begin to ask who is going to own it, but starting really with the end in mind and co-designing with the owners of the health system is really critical. The 4th being the importance of investing in national data system to improve its reliability and use. And the 5th being the importance of leveraging assistance systems, whether it is at the sub-district level, district level, or at the national level, so that we can have robust quality governance systems to address the quality of care gaps that we see. Last slide, please. So thank you very much for your attention. I look forward to addressing any questions you may have.
Thank you, Sochi. We're going to address several questions that have come on the chat, and 2 are about sustainability. Someone is asking, Sasha is asking, what are the approaches to improving the quality of care that health systems can sustain and scale without or with limited external support? And I will read the other question because I think Kathleen and Sochi can answer both at the same time. What are the key drivers to sustainability of quality of care processes and support chain beyond the grant lifespan? Could you please respond? Kathleen?
Thank you very much.
Sochi? Yeah.
Yes, thank you very much. So the sustainability question is always key and very critical. And I think the first one will be to design with the owners of the health system, because actually there are structures at all levels that have an original mandate to execute whatever it is that the project is trying to achieve. So in terms of teams, rather than say you are forming project-specific teams, there are provisions within their quality strategy for how guidelines for forming teams. So we are better off strengthening those teams rather than to create new teams. Then there's a matter of which data systems we use. So granted that within whatever project that you're working in, your process indicators may not be ones that are already being routinely collected. But once you're learning, it is important to plow it back into the national system. So you may have a child health task force, a child health steering committee, all the matters around developing referral protocols, for example, had to be brought back to the child health steering committee so that they would approve it. Once it is approved, it is no longer a project document. It is a national document, and any other partner that comes in works with that. There's also the matter of resource allocation. So now, as we've developed a quality strategy and it's being implemented, there's always the discussion for the ministry to allocate a tiny budget, for the quality related initiatives to support its ongoing delivery, so that it is not just a projectized set of activities. And the last bit has to do with the structures. So you have district health management teams with a mandate to visit facilities. They may struggle with fuel and transportation and all of that, but the more we can align our project to these, the better. So by the time we were wrapping up some of these projects, we were no longer having project-specific convenings or technical sessions. It was more around the health systems steering committee meetings that were then leveraged to deliver content. And so it was really integrated into the routine structures. And I think that was critical for sustainability.
Mm-hmm. Thank you, Soji. There are two questions related to cost that I think is important to address. One is about how much the technical support and support to hospital teams actually cost and over what period of time. And the other one is if you are able to apportion and link the contributions of the project to the observed reductions in mortality following a certain scientific formula. Maybe the first one, please, first.
Patty, before we go to the cost questions, do you mind if I just add something on the first question around sustainability?
Sure.
I very much agree 100% with everything Soji said, and I think Ankur in the chat also had some great inputs. I wanted to just give a very brief concrete example. The importance, as Soji is saying, and I think all of us are agreeing on, building on structures that exist, building capability to be able to lead this work, not as a project, but as a function of the health system and the key actors within the health system. And I just wanted to give a 2-second concrete example, which is that I know we have many colleagues from Nigeria on the line. Welcome. And in Nigeria right now, as part of the work of the Quality of Care Network under the leadership of the Division of Family Health within the Federal Ministry of Health, as well as State Ministry of Health in multiple states now, there is the development of quality of care operational plans that are led by the government, the State Ministry of Health, the Federal Ministry of Health, that include very strong engagement of all partners, that look explicitly at existent structures, that cost the activities, that outline what the key functions are of different actors. And I just wanted to bring this up because I'm sure some of my colleagues from Nigeria who are on the line could speak much more eloquently, but this is really an example of taking, applying the quality of care network strategy, functions, motivation, and really beginning to embed this within the system, led by the system, but with very strong engagement and support by multiple stakeholders and partners. So I just wanted to give that concrete example because I think we're learning a lot in Nigeria as this work is unfolding. Thank you.
Yeah, thanks, Kathleen.
So thanks a lot. I believe you posed two questions, one on cost, and the second, I think, is more about attribution. So on the matter of the cost, you are right in that the greatest cost centers were the site visits, in terms of being able to do the site visits, and then also in terms of doing the face-to-face learning sessions. So clearly this was not going to be sustainable in an actual learning, in an actual health system. So in the new phase of work, this is where we realize that even within the district level, they have mini convenings. They may not be as robust. They may not be as well structured as we conduct the learning sessions, but there are structures for health centers to come to the district for some meetings. So instead of having a 3 to 5 day learning session, you might want to have a 1-day meeting, and increasingly we are looking at that. There's some work that we are doing in places like South Africa and in Mozambique, where we are doing virtual convenings, which is also ways in which we can reduce the cost. And by way of the site visits, there are tools also for conducting some of these support without having to go there all the time. The health system itself has what they call integrated monitoring visits. So once they have the resources to do it, the challenge really will be to develop practical tools that can be deployed, because you may not have a full day all to yourself. So there are ways in which this can be done, and you have existing structures in the health system to be able to leverage to do it. By so doing, it becomes leaner and not as robust as some of the projects position it. The matter of attribution comes up very often. And I think this is where there's humility that is required on all fronts to accept that there are many interventions. In fact, the regional director of health service will tell you that it is true that you taught improvement skills, but I give them permission to come. The government of Ghana has trained people, funded their education, their inputs that are a part of the health system. So it can never really be the case that it is just entirely due to one project that saw the results. The good thing, though, is to be able to track it using the time series sequence and to be able to annotate very clearly wherever the interventions happened. And the interventions can be your project-specific interventions or Government of Ghana intervention. I recall that somewhere in 2008, 2009, the government rolled out a free maternal healthcare initiative. That initiative played an important role in causing women to deliver in the health facilities. So if you see changes in your graphs, you should not attribute it solely to your project efforts. You know, that is why you can only say that your efforts contributed. Your efforts were not the sole intervention, but contributed to a number of interventions that were happening in the health system.
Thank you, Sochi. And one last question for this section, and reminding all the participants that if your questions are on the chat, we will collect them and we will respond to them in the recording of the webinar with a list of questions. But for you, Sochi, was this restricted to private facilities, or were there other private sector providers such as pharmacists or chemical sellers involved in any way?
So the bulk of the intervention was in the public sector. It was at the point of national scale up when we worked in certain districts that it became clear that in certain districts, the main providers were private. So then we started bringing in a few private sector players. And also in the referral focused work, when we worked in certain facilities, we realized that the main intervention points were licensed chemical sellers. So some of them were involved, but to a large extent, over 98% of the interventions were in the public sector among the health centers and the district hospitals.
All right, thank you very much.
Could I just offer a reflection that may be interesting on the question of private sector? I think as many participants may know, there is a strategy on engaging the private sector that will be released soon by the Quality of Care Network Secretariat, the Global Secretariat. So I think that will be of interest. And many of the efforts related to the Quality of Care Network do involve combinations of public and private facilities and faith-based as well. So I just wanted to bring that up, that there's quite a lot of learning, I think, that's happening around bringing private and public sector together. It's not easy. We don't have all the solutions, but I think there's a lot of learning in this space. Thank you.
Thank you both. And we're going to switch now to the second part of this webinar with Ambrose and Mike. Ambrose first, please.
Thanks very much for the introduction, and to all the organizers for the opportunity to share our experience establishing and supporting a network to improve care for sick children in Kenya. Next slide, please. So in late 2013, we formed a collaboration involving the Kemi Wellcome Trust Research Program, where I'm based and Mike is also based, the Kenya Pediatric Association, the Ministry of Health, counties, and a small group of county hospitals, or what would be district level hospitals in other settings in the region. Next slide, please. So the aim of this engagement was to create a platform that could improve quality of care for newborns and children through improving generation of routine data and use of the data for improvement through audit and feedback. This network operates at the level of a county, or what was previously a district hospital. It represents a primary level of referral in the health system in Kenya, with administrative oversight from the regional or county governments, and nationally through the Ministry of Health. So we target the large general hospitals and not teaching and referral hospitals, which would be at the tertiary level, where the organization and needs are considerably different. So the platform is also currently implemented in inpatient units, focusing on vulnerable patients at high risk of death, and improvement efforts really target the major causes of morbidity and mortality in newborns and children, the newborn component having been introduced in 2015. Next slide, please. So the network partners ensure evidence-based guidelines derived from the WHO Blue Book are adapted for local use and are up to date. And these guidelines are linked to a training package, an adaptation again of the WHO ETAT training package for in-service training for providers. And linked to this, we've co-developed user-friendly structured paper medical records to serve as the primary document for clinical use, and also for the capture of data, which would then feed into the audit and feedback mechanism that I'll illustrate in the next slide, and for research for learning and improvement. So the illustration on this slide shows the workflow that drives the network and how it works really. So it starts with the clinician, who is usually an intern who is straight out of training or has rotated in other departments within the hospital, other departments not aside from the pediatric unit. And these individuals then provide frontline care using this nationally approved clinical guideline document that, as I mentioned, is adapted from the WHO Pocket Book. And they capture data on this structured network tool, which is Ministry of Health approved and provided by the hospitals. A clerk based at the hospital enters data from the medical records onto a computer, which is running open source software upon patient discharge or death at each hospital. And really this investment in the clerk and the computer that is used for on-site data entry is the only financial investment in each hospital. The data are synced daily and cleaned by a central data management team. And we give each hospital their own monthly and quarterly performance reports. And similar reports are also available for county leadership and MO and the Ministry of Health. So the central team is linked to the hospital teams in the long term, with the focal persons being clinicians, nurses, and health and information officers through regular interactions, hospital-based visits, outreach visits, skills building, skills building on technical and communication skills and mentorship. Because of COVID, we've been forced to transition from face-to-face interaction to virtual meetings. And this was rapid and obviously unplanned, but so far we've managed to sustain reasonable engagement, and credit really goes to the hospital teams who continue to demonstrate a high level of interest and participation. Before COVID, we also had biannual network meetings, which we're now rethinking in terms of how to run them under the current restrictions. Next slide, please. So what do we think we've managed to achieve? We think we've made available better quality routine data. The hospitals have successfully implemented this structured form for use by frontline providers at the point of admission and discharge. And these have been fully adopted by the Ministry of Health and found their way to health facilities which are not within the clinical network within which we work. And the sustained availability is really fully transitioned now to the hospitals, who are responsible for printing and availing these through the records departments. And then we've also observed improvements in care by frontline providers, and I'll be illustrating some of the outputs from this in the coming slides. The measurement of quality for this intervention really focuses on process measures, which you'll recall as the intermediate dimension of care under the Donabedian framework that Kathleen referred to in her presentation. We've managed to undertake a number of observational and interventional studies and supported surveillance activities as well in a wide range of areas. Many of these questions have actually been co-developed by our hospital partners and policy colleagues in the Ministry of Health. And then there's been considerable local capacity building through use of the data that have been generated to support students, local students, undertake training at postgraduate level, and several are continuing to take advantage of this platform and the resources that it offers. Next slide, please. So in the next few slides, I'll illustrate some of the changes in performance over time for selected indicators. The gray dots represent average performance for an individual hospital for records captured over a month. The black dots are monthly averages across the hospitals, and the gray lines are the upper and lower interquartile bounds. And the selection of indicators and targets for performance are done through consensus by the hospital teams themselves. So from this slide that is looking at assessment of nutritional status through the use of assessment of mid-upper arm circumference over time, you can see there's wide variation from site to site, but evidence of overall improvement across the sites over time. Next slide, please. A similar trend is seen for assessment of HIV status for hospitalized children, which is one of the standards for care for admitted children and in our national guidelines. Next slide, please. And on this third one, which looks at the use of pulse oximetry to assess oxygen saturation in admitted children, you can see there's a lag at the beginning. And we think that this is because of the operational challenges implementing technologies like this, which range from procurement of equipment to ensuring availability and appropriate use. Next slide, please. So to summarize, I've shared the work of a very, very large team of partners who have been engaged in the generation and use of routine data in hospitals. To avoid overburdening the frontline providers, data entry is performed only once as part of routine care. We've observed improvement in the quality of data and also performance of selected indicators to track the quality of clinical care for admitted children, and also used the same data to conduct locally relevant research to further expand the evidence base for clinical standards in Kenya. So I'll end by thanking everyone for their attention on behalf of the entire CIN team. Should I hand over to Mike?
Yeah, and then we pass it over to Mike for the last presentation.
Good afternoon or good morning, everybody. And it's a pleasure to be here, and thanks for inviting us. I'm going to talk a little bit differently now. And I don't have many slides, and I hope the slides are quite simple. But I apologize, I can't give this talk in French. So I hope our French-speaking colleagues are able to follow what I'm saying. You've heard some fantastic presentations and examples of how to do quality improvement and what quality improvement is. What you can often be left with is an impression that quality improvement is like a structure, and it's almost like a machine. If you put these pieces together, then the machine will work and you will get the improvement. And while Soji demonstrated that it can work very well, I think we know from much wider work across the whole world that it doesn't always work well. And what is often a bit neglected when people talk about quality improvement is how do you make it work? And if you think about it, what Soji described and what Kathleen presented in her framework was actually a massive effort to change people's behavior. So you have people in health facilities typically, and you want them to get each individual to do something differently. You need the person that's organizing or supervising those individuals to do something differently. So we're looking at individual behavior changes, and we're also looking at social changes and organizational changes. And one thing that medical and public health people often do is forget that there are many other scientists with very important things to say about the way things can work. So how do you change people's behavior is extremely well studied, but often these ideas are not really brought in fully into our thinking about quality improvement. So in this very simple set of slides I'm going to show you, you'll see on the left side, well, for me, at the bottom of this 2 blocks is the motivation of individuals. And we all know that you need to motivate people if you want them to get them to do something. Why should they do it? They may be able to do it, but once they're able to do it, then they have to then carry on and perform it. So how do you motivate people? And we've learned a huge amount across multiple different branches of science about how you motivate people, and it's not always the same. And there are quite specific things about motivating people who are in professional and vocational roles, such as health workers. They don't often respond in exactly the same way that somebody who is being paid to produce a certain number of items in a factory. So we actually need to be thinking in the right way about how to motivate people. And ultimately what we're trying to do, and what Soji was doing over those years, and what we've been trying to do in Kenya over years, is begin to get people to feel that improving quality is actually part of their normal work. And it doesn't require somebody to tell them to improve quality. They're constantly thinking about improving quality. And this is what Soji partly referred to as culture. But it's interesting, and I think, Soji, if you'll forgive me, you actually even use the words culture and all of those things. All of those things are actually critical, because if you cannot get the culture to work, and then the quality improvement will likely only work as long as somebody is really there to push it and drive it themselves, which means that's the sustainability issue. So we have to think carefully about what we're doing to individually motivate people. And we've also learned, again, over decades, this is not new, that if you have teams of people, those teams need to be able to work together. Those teams need to trust each other. Teams work well, and I'm sure many of you have experienced this. If I'm going to be half an hour late for my work, then I can call my colleague, and my colleague will stay half an hour to make sure there is somebody there. But they will only do that if they trust that the next time they are late, they can call me to cover for their problem. So trust is critical to the way that our teams work in health facilities, and we have to be able to build it. And that means that the people who are in charge of the teams need to have the right skills. And often what happens in quality improvement work, and it's not thought about, but it happens, is that we're often building the teams. We're helping groups of health workers to get together, to think together, to work together. And that's actually a role in building teams. And there are good ways to do that and less good ways to do that. So sometimes quality improvement doesn't work because the person who is trying to facilitate all these health workers to do things differently is not very good at facilitating. They're not very good at helping teams in hospitals or in clinics to work together, which means the leaders of those teams don't learn themselves how to facilitate and how to build trust. So these things are critical, and if we are more explicit about thinking about them, we may actually perform our quality improvement better. But next slide, please. So I talked about individual motivation and teams and trust. And leadership was mentioned by Kathleen. It was quite obvious from the work that Soji was talking about and from what Ambrose was talking about that leadership is important. And we all know this implicitly. We all know that we cannot get a health facility or a hospital to change unless some of the senior people in that facility want it to change. So the local leaders are critical to many of our improvement efforts. They're very influential, they have authority, and they can make or break our efforts to improve quality. But many people who are in those positions, such as a senior doctor or a senior nurse, they've never actually been given any skills in how to be a leader. And if we think that they are important, then we need to be able to give them the right skills. And this can occur by accident in QI projects when the QI team who are helping set up the project are good at this. But again, if all you have is a set of policies and a set of tools that have come from the government, that doesn't really tell you how to build this local leadership. More at a higher level of scale, I think we all recognize that, particularly in health, our professional bodies, our nursing associations, our medical councils, our medical associations are very important things. They're not just important because they are a collective identity for us, but they also set what we call are the norms of the way we behave. So, and people who are trained in a certain setting will learn the patterns of behavior they see in that setting. So again, you'll all recognize if there is a senior person that when you were a junior person that you saw acting in a way that you really admired, then you are likely to try and practice in the same way. It's very influential. Conversely, if a senior person acts in a way that you feel is inappropriate or poor, then you will not be inclined to act professionally yourself. And if we're trying to change the way systems work, we actually need to think about changing the way that the professions work and the professions think of themselves. And again, there's lots of theory that can help guide us in this if we take it seriously, but it's an active process. It doesn't happen by accident. Next slide, please. And you can see here that I've introduced the ideas together with these now of governance, and there is governance by measurement, which is becoming increasingly the focus of things. If you can't measure it, you can't manage it. That's actually nonsense. That's completely wrong, because most governance is actually guided by our norms of behavior. It is no longer acceptable to beat a child in school. That's a norm, which in many countries was not the norm 20 years ago. You don't need to measure that. It's now something that happens because of social pressure. So social pressure, that form of governance, is extremely important in trying to build quality systems at scale. And we also heard from Soji's presentation and from Ambrose's presentation and from Kathleen's implicitly that we're often using feedback to help people change. And there are many things we know about how to make feedback work better in terms of how we give it to people, the way it's presented to them, but also the way in which we talk to them about their performance. So there is a huge amount to learn about how to do quality improvement that cannot be written in policy documents and is not part of things like PDSA cycles. Next slide, please. So this is just the summary of, we need to be thinking much more about how do we change systems broadly that go beyond the technical approaches to quality improvement. And that requires long-term, large-scale efforts, and we must involve very important partners like medical schools, nursing schools, professional associations, otherwise we won't achieve long-term change. Let me stop there. Over to you, Anne.
Thank you so much, both Mike and Ambrose, for your comments and the presentation, Ambrose. So we have a little bit more time for a few questions. There have been no more questions in the chat, but if anyone wants to talk and make a comment, please do so. In the meantime, I'm going to ask a question to Mike and Ambrose, and Soji, you can come in too if you want, about motivation. That was something that someone actually brought up in the previous round of discussions on what was done to increase motivation of health workers. And the question for Ghana was of traditional birth attendants in order to refer mothers, but also in the settings where you've worked, Mike and Ambrose. You know, what were the factors that really increased the motivation of the health workers to take this on and internalize these processes? Was it the regular review of data or seeing the results? So maybe you can share a little bit about that.
Maybe I can jump in first, and then Ambrose and Soji may want to comment. So I think there are very many things that are motivating for people. Many people in global health at the moment immediately think of financial incentives and pay for performance. And for those of you who don't pay so much attention to the research literature, then when they bring all of the results together from those kinds of experiments, the average effect is 0. So financial incentives may work sometimes for some people, but they are by no means a simple and reliable means to motivate people. In fact, sometimes what's been found is that particularly for people who are in vocational professions, and that includes health workers, teachers, others, if you try and pay them to do things that they already recognize are important to them professionally, it may actually make things worse. And this is a problem called crowding out. So one of the things that actually many of us respond to, and maybe we're all a bit, maybe it's just a bit sad about us all, we actually all respond to recognition. We like, if people tell us we're doing a good job, we like, especially if we are doing a good job. So they don't like us, there's no point telling somebody they're doing a good job if they're doing a bad job. But if they're doing a good job and you tell them they're doing a good job, they really appreciate it. And it is very motivating for people. And I think getting people together, as Soji talked about and Ambrose talked about, so they actually meet each other, they discuss, they feel that people are listening to their challenges. And they also are part, and this is what quality improvement does very well, they're part of generating the ideas for solutions. So they own the ideas. And so because it's their idea, they're keen to try and put it into practice. So I think there are many things that motivate us, but again, I think it doesn't matter what work you're in across the world. If you're in a team of people you like, that's probably the most motivating thing for you to go to work every day. But let me stop there. Over.
Thanks, Mike. I don't know, Ambrose, you want to come in here as well?
Yeah, but just to agree with what Mike has mentioned, I think the network effect has been an important driver. Peers linking up together and essentially sharing their experiences. And I think it's important to note that this does take time, and individuals need to learn to gel with each other. And I think that touches on Mike's earlier point around trust. So we've found that individuals within the network have formed almost like a true community of practice where they can openly share and exchange about issues that touch on work, but even outside of work, recognizing achievements that extend beyond professional circles. Thanks.
Thank you very much, Ambrose. We have one question which I think links quite well here on motivation and feedback, Mike, that you get, and either of you can respond, but it was about patient or user feedback and accountability mechanisms, also as you know, one way to increase motivation and feedback.
Yes, thank you. There was also, I saw in the chat, a quick question on social pressure. It's a long discussion, but let me give you a quick example. And I'm sure Soji would have many as well. And so when you bring peers together, and one of the peer group says, this is something I did, and it appears to really work. And I'll give you the example of when the young doctors arrive on the ward, to actually do a whole day of induction, explaining everything to the new arrivals on how these things work, what to do. That didn't used to happen in our hospitals. So somebody came to one of the meetings and said, I did this for my new staff and it really worked well. And within a few months, most of the hospitals that are part of the network were copying this. And it became something, if you didn't do it, it was regarded as something that was actually not such good practice. So that becomes a kind of social pressure to adopt that form of practice. More specifically on using feedback, I think the issue there is if you need to, people will respond to feedback if it's presented in a good way and if it's things that they can act on. There is no problem, no point telling somebody that they're performing very bad. And we have a good, you know, a typical situation where we tell people that your performance on checking the blood glucose of very sick children is very poor, but they don't have a blood glucose machine, and there's nothing they've tried and they can't get the hospital to buy them a blood glucose machine. So there's no point giving them feedback, constantly telling them they're doing badly for a problem they cannot solve. So we just need to be clever about feedback. Again, it's a long conversation, but it's not as simple as sending somebody a piece of paper saying this is your performance. It's much more subtle than that. Over.
Thank you, Mike. We have to close soon, but I see a hand up from Soji. I will respect that, Soji, and then Wilson, if you want to come in after that for a very short comment. I saw your hand up too, and then we have to close.
Just a quick one on the motivation. I agree with everything that Mike and Ambrose have said. Just to add that it was really motivating to identify what it is that increases the self-worth of the people. So in the case of the traditional birth attendants, for example, we realized that they were highly valued in the communities. So instead of saying that, well, women can no longer deliver with them, trying to modify their roles to say you can accompany the women to the facilities, you can even stand by to support the labor process, but you don't have to do it yourself. Preserved their sense of self-worth. The second one is empowerment. So that whole process of using data, you know, made the health workers understand that actually they had the power to effect change at their level. And I think that was very motivating to them to realize that they didn't necessarily need more doctors or more midwives or whatever, but they could make small changes that would impact the quality of care. That's just what I wanted to add.
Thank you so much, Soji. There were many interesting questions that came in at the very end, and we will ask our presenters to help us respond to those after the webinar so that we can share responses with you. There was a very interesting now about the really need of changing norms and culture and how to do that. Mike, I'm sure you have a lot of thoughts on that. Thank you everyone for this really very, very interesting session. So we learned about principles and standards and processes for improving quality. We really, I think, heard a lot about the importance of measuring what is being done, about motivation, and learned about these great efforts from Ghana and Kenya really at a large scale to improve quality and how this has been impacting outcomes and engaged governments to further scale these initiatives. So thank you very, very much. Merci à tout le monde. J'espère que ça allait plus ou moins avec le français. On va améliorer la prochaine fois. You will be shared the recording and the slides after this webinar, plus additional resources. Thank you very much. Bye-bye.